All right, everyone. I wanted to introduce our guest speaker, Dr. Arturo Carillo. He's a licensed clinical social worker and director of health and violence prevention at Brighton Park Neighborhood Council. Dr. Arturo has led the Collaborative for Community Wellness to research and document the inequity of access to quality mental health services throughout low-income communities throughout the city, and advocates for the creation of citywide non-police crisis response program grounded in an expanded publicly operated mental health system in Chicago through the Treatment Not Trauma campaign. And I will let you take it from here, Dr. Carillo. Thank you.
Yeah. Well, thank you for having me today. I apologize that I can't be on camera. It's for some reason not allowing my video to connect. Well, thank you again for inviting me today. As was mentioned, I'm a licensed clinical social worker by training. The focus of my work has been very much based around mental health advocacy for many years now. But I'm very happy to be here today. I know focusing on people's lived economic experience through their occupation is part of the content for this week. So it definitely is. I'm happy to talk about it more. That was a part of my research that really propelled me through the PhD program, where I focused my dissertation work on assessing workplace advocacy by examining all of Chicago's worker centers. And so for me, coming out of that experience of assessing labor rights and workplace exploitation, really set me up to think about what economic justice and social justice looks like in our field and in social work in a way that wasn't really explored and wasn't really covered at the time when I was in the PhD program. Social workers love to talk about poverty, but not necessarily examine what are the social and economic conditions that continue to push it forward. Of course, we know that people's employment and low wage sectors of work contributes, of course, to people staying in low socioeconomic standing. So my dissertation work was really geared on examining how it is that organizers within the worker center movement saw their role, understood the issues as it related to people's lived experience in the workplace, and also within their community, right? Identifying how people's socioeconomic standing impacts other parts of their work. Other parts of their lived experience was part of the work of the worker centers, right? So I'll start today's presentation by examining some of my findings and kind of walking you through what was the process for me in exploring this issue. I hope it helps you all as you're entering in the public health world to think about how structural violence, as we term it, impacts the lives of those that we're here to work with, right? So let me go ahead and share my screen. Okay. All right. Can people see this presentation here?
Yes.
Yeah. Okay. All right. So, for me, as I mentioned, I'll give you a little bit more about my background. Although I'm a licensed clinical social worker and received my MSW at UIC, my background actually was through working on the Southeast Side, where I'm born and raised, around worker issues and establishing what was the first worker center to be established on the Southeast Side. So my work during my MSW studies also was at the time of my life that I also was part of co-founding Centro de Trabajadores Unidos United Worker Center on the Southeast Side. at the time, I was very much involved in the immigrant rights movement. I was part of the mobilizations that happened in 2006, 2007, and into 2008, where people were throughout the country organizing around immigration reform efforts. So for me, very much being part of that space showed me firsthand what community organizing, what activism, what grassroots organizing looks like. And as I, lived my entire life on the Southeast side, I saw both from my personal and family experience, but also through the shared experience with many of my community members, what the impacts of people's working conditions had on themselves and their family, right? So workplace exploitation was something that I was very much interested in learning more about. As I was part of the immigrant rights movement, I was seeing firsthand what other parts of the city, other organizations throughout the city were doing around this issue. And we felt that it was important for us on the Southeast side to develop a worker center that can also examine, how structural oppression is manifested in marginalized communities, right? So that was, for me, what was the draw to being part of developing a worker center on the Southeast side. It also was, for me, kind of what I had forever present in my dissertation studies, right? For me, thinking about workplace exploitation and understanding what are the driving forces, what is leading to this sort of treatment in the workplace, and in many cases going against what are established laws and protections for workers, that both include workplace conditions, but also understanding of people's wages and benefits, right? So for me, really understanding what are the driving forces that cause workplace exploitation, but also what can be done to resist it, right? And so, for me, the worker centers were that case study where we could understand what can be done, right? What is it that marginalized communities can do to gain power, to challenge oppression? And so I took it upon myself to design my dissertation studies around an examination of the worker center organizers, right? So I was able to interview all of the organizers at the various worker centers at the time. I'll get more into that in a few moments, but just to kind of further set the context, for me also, I saw Chicago as a global city, right? We understand the global city as a geography that has constant tension between centrality and marginality. We know there's increased disparities and almost this understanding of Chicago as a tale of two cities, right? That is characterized by contestation, right? The tension that is held between the opposing forces in this economic inequality that we see. But also understanding that Chicago is very much a place in which the marginalized communities can make claims on the city, how we can in Chicago make an impact that has very much a national that has national exposure given the city that we live in. One of the things that for me was very interesting in doing my dissertation study was that through my interviews, I was able to also gather what was a history, a very dynamic history of how the worker centers came to be. And many of these worker centers had roots in social service organizations that were tending to the needs of individuals who were, again, dealing with workplace exploitation with a very much social service approach, right? And you'll see in my findings how social service organizations often morphed into advocacy organizations or splintered to create advocacy organizations that are now commonly known as worker centers. Finally, for me also, my dissertation work, and I hope this is useful for you, because for me, finding a conceptual model that can really explain and help us understand how these driving forces impact the people that we're serving and where and how we can establish interventions was very important for me, right? And for me, I was having a hard time finding a conceptual framework that could capture how we understand the issues that are facing immigrant workers, low-wage workers, and other vulnerable populations in the workplace. So understanding and finding structural social work as a conceptual model was very much eye-opening for me. So I'm going to start my presentation again focused on some of my dissertation work to set the context, but also explain to you how I've carried that forward into our advocacy organizing around mental health access in Chicago. And again, still using that same structural social work model for me has been very helpful. So the research questions I examined are here. I really want to understand how various factors presented, how are the various factors present in the lives of immigrant low-wage workers, excluded workers, and excluded workforce in particular, elements of personal, cultural, and structural oppression, how are those understood by the worker-centered organizers, right? I really wanted to kind of keep an open-ended question, right? As I was interviewing participants in the study, trying to understand how they're understanding, right, the intersection of personal and interpersonal, cultural, and structural oppression. Like, these were the three areas that for me kind of set the framework for understanding then where and how interventions could be made in the three areas that structural social work examines, right? So that of course leads into my second question, which was the understanding of the interpersonal challenges, right? As Malady, I'm sorry, not Malady, Malady, sorry, Bob Malady, the author of Structural Social Work, and I'll explain this a little bit more in detail later, but understands the interpersonal struggles presented in the lives of people as a superstructure, right? And how does that interface with the structural challenges, right? The social institutions that uphold our society, and how does that interrelate with our substructural or ideological area of our society, right? How is it that these ideologies drive and have an interplay with these other two levels of our society? Again, I'll explain this in a minute, but it really kind of gave me a framework to again understand and break down what the issue looks like for low-wage workers in this case, but later, as I'll mention, talking about what mental health access looks like, and how does the same structural framework help us understand where and how interventions have to be driven to change this reality. So I was able to interview 18 participants at 8 worker centers. It was very much a very rich exploration and allowed for various deep conversations that through these extended interviews were able to uncover, both their assessment of the community that they were serving and supporting and mobilizing and advocating for, but also what was their own personal and historic understanding of the work that they were engaged in, and why were they doing the work, what were their own ideologies that were driving them into this field. It was very much an eye-opening experience for me, and the part that I really was surprised to discover was how rich of a history there was, right? Of course, I was entering this research in a time and place back in 2000. This is back in 2007. No, I take that back. Sorry, I apologize. 2017, where I was really walking into a study that was engaged with fully functional nonprofit organizations, right? These are all 501c3 organizations, nonprofits, but very much that saw that acted and served as a role of advocacy organizations in a way that I was very much in admiration of, right? Because these were organizations that were operating on very small budgets, but we're making a very significant and impactful change in the lives of the people that they're serving, but also policy-wise, right? They were changing policy at the state level that really had an impact for workers throughout the state, right? So they were thinking about their interventions both as interventions that were very much supporting individuals, but also thinking about systemic change through policy that needed to happen, right? So it was very, very much an eye-opening experience. And understanding the history and the development of worker centers in Chicago was one of those interesting findings within my study. I was able to capture through these interviews people's understanding of the various waves of worker center development in the city of Chicago, right? What I termed the first wave was kind of like the pre organizations, right? These organizations that were not necessarily all focused on worker rights, did not at that point did not use the term worker centers, but were very much grounded in supporting communities that had been marginalized and very much dealing with the oppression of the time. I mean, through my interviews, I was able to collect experiences and people's involvement with various people who were part of that first wave, or they themselves were part of this first wave, and it was through these informal and sometimes loose organizations like the Association for Worker Rights in 1969, to very much precursors to what then became worker centers of the second wave, which was, for example, the Chicago Interfaith Committee of Worker Issues later became ARISE. Actually, it was not listed here, but the Chicago Coalition for the Homeless spun off two worker centers, Latino Union and the San Lucas Worker Center during that second wave, right? Because they were seeing that the homeless population at the time, Chicago Workers Collaborative was also part of that. The homeless population at the time were often part of the low-wage workforce, right? They were part of the jornaleros, the day laborers, and seeing that people who were working were also homeless led to this understanding that temporary employment also was very much causing this situation of exploitation that led to people to be in such a vulnerable state, even as they are being employed through these precarious employment situations, that an entire part of the worker center movement dedicated itself to day laborers, and that was through the work of the Workers Collaborative and Latino Union. Finally, through the breakdown that we saw, that I saw through the interviews, was that many of the worker centers also were very much cognizant of what was a flourishing movement at the time, what they called what was termed as a third wave, where you see various worker centers start establishing themselves throughout the city, in areas of the city that didn't have worker centers, but also the infrastructure that was necessary to carry worker centers into this policy advocacy space. Notably, the Working Hands Legal Clinic was established in 2007, where a former union organizer turned lawyer worked with who had deep roots in Chicago and very strong connections with worker centers, established the Working Hands Legal Clinic, which was the first legal clinic of its type here in Chicago to work exclusively with worker centers to file lawsuits against employers who were exploiting workers through wage theft claims, but also identifying that legal strategies were limited by the law itself, right? You can file a small claims filing in court to regain wages that are owed to workers, but that's really the job that the Department of Labor should be doing at the state level, right? So to think about what policies need to be introduced to strengthen the Department of Labor became part of what was also the strategy of this legal clinic, right? Understanding the legal clinic and the legal strategy can also support, by way of supporting worker centers, also support legislation that could be introduced in the city to strengthen workplace rights and protections, and strengthen the enforcement bodies that are in place, as in the Illinois Department of Labor, to protect workers, right? So through that coalition, you see the establishment of the Raise the Floor Alliance in 2014. And the Raise the Floor Alliance became a space for worker centers to unite, to change advocacy, to advocate for changes in policy that would strengthen workplace protections for all workers in the state, right? So you see kind of this sophistication within the worker center movement in Chicago really take hold after the establishment of Raise the Floor Alliance, which to this day continues to advocate for workers' rights throughout the state in conjunction with all these work centers. So it was very interesting to see kind of how that evolution occurs. one of the things that, I'm showing here on this slide, was very important, as I mentioned, which was my first research question, was asking the organizers to identify what are in their experience in working with the multitude of workers that they work with. What was it that for them they saw as examples of structural, cultural, and personal oppression? And so, of course, what I found in the interviews was that poverty and the interrelation of various social issues present themselves in the lives of the workers, right? We found that I found in the study that workers, of course, were dealing with situations in the workplace, but also they were challenged with housing issues. They were challenged with access to services, the lack of access to services for themselves and for their families. There was a long list of personal barriers and challenges that workers were facing, that worker centers were keen to trying to also provide linkages to resources, supports. Health issues are very much present. So trying to find resources and health supports for workers was very important. Um, you know, Issues that were very specific to the undocumented community, for example, lack of a driver's license, right? A lot of these organizations were also working within the immigrant rights space to advocate for increased access to resources that could benefit them and their families, like, for example, having access to a driver's license. Right, all of these issues were very much convergent in the lives of workers. Which was not much of a surprise, right? But to understand that worker centers were also understanding that these social needs are very much intertwined in the lives of workers, made it so that their work couldn't be exclusively labor or organizing. In some cases, some organizations also had a very strong social service component that was built into the worker center, but that varied by organization, of course. Thinking about how oppression is present and delineated in the lives of workers was very important for me in this study, right? So understanding how exploitation, marginalization, powerlessness, cultural imperialism, and violence were present in the lives, in the experiences of workers in the workplace was very, very, very telling. So there was a lot that I was able to examine for my dissertation in understanding how cultural and personal oppression presents themselves in the lives of workers. Again, this was part of me understanding what are the problems and challenges facing the workplace, to understand then what can be done to challenge those structures, right? So finally, thinking about structural oppression was very important as well, right? Because again, understanding what are the labor, regulatory, immigration, and economic systems that allow for conditions to establish themselves in the workplace that can create situations in which employers are very much taking advantage of the lack of labor regulation, for example, to continue to establish exploitation in the workplace was important. I'll give you a quick example. At the time, the Department of Labor had very limited regulatory power when it came to wage theft, right? So there was a study by Nick Theodore that quantified the amount of wage theft that was occurring throughout the city of Chicago. And I don't have the number in front of me, but it was something like 7 million, or actually, I don't want to misquote his research, but the amount was very much surprising to many at the scale of wage theft that was occurring. To understand that every worker who had unpaid time, unpaid overtime, who had wages straight up stolen, right, where they were not being paid for their work for the week. The level of wage theft in Chicago was very much surprising when Dr. Theodore was able to quantify how much that was in Chicago. But what the worker centers were very tuned into was that this was not by accident, right? It was really much happening because of a design, right? The Department of Labor itself was not actually enforcing wage regulations in the state or in the city in a way that could have checked this sort of exploitation in the workplace. The Department of Labor at the time, when and if and when an employee had his wages stolen, they themselves had to initiate a complaint with the Department of Labor. So assuming that the worker knew that the Department of Labor was the correct place to file a complaint when your wages were stolen, assuming that they actually had the capacity and were able to go downtown and fill out the forms and submit them to the Department of Labor, the Department of Labor itself was investigating these claims in a very delayed fashion. So it took some time before they would even open the investigation. When the investigation was opened, if the owner cooperated in the investigation, and if the Department of Labor found that they were in fact liable for what was the wages that were stolen from the employee, the Department of Labor could not actually enforce wage collections. The Department of Labor itself could not actually fine the employer when wages were stolen, when they were found guilty. What the Department of Labor would do would send them a stern letter saying that they were liable for these old wages. The employer would then take that letter, throw it in the garbage, and that's where the case would end. Right? The worker themselves did not actually were able to collect the wages that were owed through the Department of Labor. The enforcement mechanism was not there. And so one of the things that the worker centers did through the Raise the Floor Alliance was they introduced legislation that for the first time ever, and it became the strongest legislation in the country when it came to wage theft, for the first time ever, employers would be fined if they did not pay back the old wages to the employees after they were found liable for the stolen wages. But if an employer continued to break the law in this case, they could actually face jail time, which was to the workers themselves a no-brainer, right? Because if the workers themselves stole from the employer, they could face jail time. But if the employer stole from the employees, there was no consequences for that action. And in many cases, it was thousands of dollars that these low-wage workers depended on to pay for their rents, right? To just have as we all do, right? We rely on our wages to our cost of living expenses. In this case, right, it took the worker centers through this advocacy to bring legislation forward and pass it at the state level to finally give the Department of Labor the regulatory power that it needed. Again, and to make this legislation even stronger, what the legislation called for was that the fines and fees collected through these investigations would then be reinvested into the Department of Labor to hire more investigators, right? With the idea that these sort of investigations should not be reactionary, but they should be proactive, right? The idea that the Department of Labor can proactively investigate wage theft claims instead of having to wait for the employee to have to file for those claims. So again, I'm going down this specific example, but to me, it really brought together what was this understanding that people who are facing this sort of exploitation, addressing their immediate needs is very important, but also changing the structures that allow for this to occur. I'm going to just skip ahead here to this slide. So as I was mentioning structural social work, when we think about people's lived experience, right, this is the model that for me was very much grounding in helping me understand conceptually, right, how and where our role as advocates can be grounded in. This is a conceptual framework that comes from Dr. Mullally, a theorist in Canada, who uses this model to understand the relationship between people and their lived experience of exploitation, as he terms it, in the social relational space, right? This idea that we exist in a space that is upheld. Think about a platform or a bridge, right, in which all of us exist in this social relational space that is being held up by these pillars that you see here listed as social institutions. And these social institutions are economic systems, political systems, the welfare system. You could go on and on listing the various systems that established the social relational space by way of laws, regulations, structures, systems that create our lived reality. He also very intentionally separates our foundation, right, the foundation of society, right, as a substructure. Again, going back to this analogy of a bridge, right, the bridge itself, when we look at a bridge, we're able to see the pillars that hold up, right, this platform in which people, our society is very much existing. It upholds this platform, and it shapes our lived reality in the social relational space. What's out of sight, which is just as important, is the foundation, right? We don't see the foundation that's buried way beneath the pillars that hold these pillars. In this analogy, our ideologies, right? The ideologies of our society, the dominant ideologies of our society, are very much where that foundation is out of sight, but without it, right, the bridge wouldn't exist, right? So how is it that our ideologies inform and influence both the social institutional space, but also the social relational space? He challenges us in our field to think about what is a dominant paradigm? How is it that our society is structured based on a liberal paradigm, an ideology that's composed of individualism, right, that is very much driven by capitalism, that is very much racist in many ways, very much perpetuates inequality through this justification of white supremacy, right? Thinking about how our representative democracy, right, our political system, and this ideology that we have that representative democracy is the best form of governance. This idea that limited intervention, think about people's ability to pull themselves up by their bootstraps, right? These are the dominant ideologies that shape our society, that also again reinforce the pillars and define what our welfare system, our education system, our political system, our economic system looks like, and how that creates social relations that again reinforce classism, patriarchy, ableism, sexism, ageism, imperialism, racism, heterosexism, right? Like this idea that for us, the design of our society is very much reinforcing oppressive systems. He, of course, thinks about, and this is something that's very common within organizers, right? This refrain that we think about the world as it is, and we work towards the world as it should be. That is very much the motto of organizing. And thinking about the world as it should be is where he is able to put side by side what an alternative reality, which he terms a socialist paradigm, could look like, right? And how we work within our existing reality to push towards, right, systems that are more reflective of our ideologies composed of collectivism, right? This idea of need-based distribution, equality, participatory democracy, right? Not just representative democracy, a planned economy, right? Solidarity. This idea that our regulatory systems can be strengthened to support an ideology of equality, right? So that again, workers have the same rights and protections from theft as the capitalist interests do, right? Thinking about how, in the example I just gave, right, we can use a political structure to build up the regulatory structures that support workers, right? And so, for me, examining this, where and how our foundation can drive oppression, but also how operating within the social relational space can also help us resist, was very important. So if you notice in this conceptual model, which is just the same one I just showed, but I flipped it upside down, where I was able to think about the work of the work centers was their placement between the social relational space and the social institutions, right? They were very much that bridge. They were very much part of the linkage between people who were dealing with exploitation in the workplace, who maybe didn't understand or care to know the social institutions that were driving oppression. All they knew was that their check came up short that week, and they were counting that money to pay for rent, and now they were stuck, right? Now they needed help, and they reached out to this local nonprofit that they heard about, and that local nonprofit was able to support in filing those wage claims with the Department of Labor. Right, but the worker center organizers themselves knew that filing to the Department of Labor was very much not going to resolve the matter, and it would take legal support. Again, they did have a legal clinic at the time to be able to collect the money. But again, the attorneys who were filing these lawsuits were not just doing that for the sake of collecting legal fees. They were very much also trying to use that as a vehicle for legislation that would change how workers were able to develop strategies to collectively with the organizers themselves to change the system itself. Right. So one thing that I was very clear in understanding how the worker centers created a space for resistance was in developing leaders. Right. This worker who had, again, experienced wage theft walks into an organization as somebody who needs support. Right. And again, a social service model of practice would have just filed the paperwork for him, maybe shown him where to fill out the forms, helped him through the process or her through the process of filing the forms, and leaving it at that, right? But worker center organizers very much about accompanying people through the process that they needed to resolve their own problem, but also developing them as potential leaders that could be engaged proactively in their workplace and in their community to support others and to bring others into a space of collective organizing, right? They were very much actively challenging racism and xenophobia and sexism and classism through their work in building these leaders. They were understanding the trends through this understanding that these leaders themselves have the collective knowledge necessary to think about what the solutions are as well. Right, so developing the legislation and having leaders going to Springfield to advocate was very much part of the workers themselves having a voice and finding a voice to bring what was very much a personal problem into the political space to change against systemic situations that were causing that problem in the first place. We saw that workers' power was manifested through social power, right? Protests, mobilizations, direct actions were very much part of the strategy. Building economic and political power was a bit out of reach for some of these worker centers individually, right? One worker center in of itself was very much limited as to political power it could flex in supporting workers, but as a collective, right, through the Raise the Floor Alliance, right, where you're representing workers that are now constituents of not just one congressional district, but various, right? Not just one ward, but wards throughout the city. Give it the opportunity to build political power in order to make that change. Addressing limitations of the labor regulatory system, I spoke about this through that example. It was very important to think about where and how the system itself was failing workers, right? So one example I gave was the Department of Labor, but another was labor unions. The worker center system itself operates in the nonprofit space, right? Separate from the collective bargaining union labor space that traditionally upheld worker protections in the workplace, right? These worker centers were operating in workplaces that were not unionized, that will not be unionized, and challenging the unions themselves to be active supporters of workers that were maybe outside of their own membership base, but also even when workplaces were unionized that were not representing the workers, challenging the unions themselves and driving political discourse into the unions themselves was very much part of the strategy that I found very, very, very interesting. Finally, one of the elements that were developing within certain worker centers was this idea that worker-led cooperatives, establishing of co-ops as an alternative economic model that could support worker empowerment was very much taking off at the time. Some co-ops have developed since, and now stronger language and legislation, both at the state level and the city level, has been established to create co-ops as a formal business structure made available to workers throughout the state, right? So thinking about even this new economy, what a new economy, alternative economy could look like, in which workers themselves are owners of the business has been a strategy that the workers centers have carried forward. Shared spaces, collective kitchens, for example, for street vendors, cooperative kitchens have been established since then, right? So there's been very much a movement to think about what a different economy could look like. Finally, the worker centers were very cognizant of ideologies as both important too, but also one of the limitations of our current system, right? The workers center organizers themselves were very much understanding of the impacts of capitalism and the type of capitalism we have in this country, a very different form of capitalism that we see in other developed countries. They were very much aware that this kind of cutthroat capitalism is very, very much why workers were dealing with this experience. But they found that, unfortunately, right, this was not part of the discourse that you were seeing in the workplace, right? Workers were very much grateful for having an employment opportunity, as exploitative as it was, that did not think about what class consciousness, right, has to do with our ability to mobilize workers in various sectors and across racial, gender, and economic lines. But thinking about how strengthening this class consciousness had to be part of the work was very much on the forefront of what the worker center organizers were thinking about. Again, they saw some challenges with the Linsky style organizing. They also saw very much a big problem in this country in which unions organize without a fully developed class conscious ideology. And can be very much perpetuating racist and other oppressive ideologies themselves that leave out various types of workers who are part of the class of workers that the worker centers are organizing. And politically, right, at the time, there was very limited discourse from the left that seems to have developed further since then. At the time, Bernie Sanders was very much bringing forward left discourse into the mainstream political dialogue in a way that the worker center organizers themselves were very excited about, right? So, again, there's so much to be said about what was captured through this research, but it was very important for me as a social worker to think about what our role in understanding our own ideology. How does that ideology shape what we learn in the classroom? How does that ideology shape what we're not taught in the classroom? How does that ideology shape our work as professionals? Really helped me think about what my role as a licensed clinical social worker and understanding what mental health access looks like in Chicago looked like. So really quickly, I'll segue into my work around the Treatment Not Trauma campaign, which has been something we've been working on to address mental health access in the city of Chicago in much the same way that I was seeing organizing happening around worker centers, right? How do you bring people who have been exploited by the current situation, those are the experiences that they have, how does that inform our organizing campaigns in a way that could challenge this neoliberal agenda, right? This neoliberal ideology that really drives the way our systems and our institutions are set up and where and how resources are invested and how they are not invested. So if I could share my screen one more time, let me pull this up and then, okay. All right. So once again, I'll start with the structural social work model, but this is actually an exercise that I've done with students when I've taught a class on structural social work in the College of Social Work at UIC and at University of Chicago. We were able to use the structural social work model to again think about what does mental health access look like, right? So going back again into our understanding of structural social work, right? We think about the social relational space, which is here shown on the top. We have again, just like the worker centers, we're very much engaged in that space between the social relational space and the social institutions. The Collaborative for Community Oneness, which is our coalition that's comprised of many nonprofits, community organizations, stakeholders, IPOs, political action groups. the Collaborative for Community Wellness is a coalition that brings together voices in a space of supporting those who have lived experience of limited access to mental health services with challenging those political and social structures that perpetuate this inequality. And also, again, very much grounding it and rooting it in our ideologies. So I take this from an article from Dr. Matini and Holtschneider that define in their research how structural violence and structural social work practice are related, right? So I'll just read the quote really quick. They define structural social work and structural social work interventions as a practice that challenges oppression and structural violence, that offers care and accompaniment for the casualties of oppression, and co-constructs a society of individuals and collective well-being and liberation. Right? How can we involve people into the solutions of the problems that challenge the systems that maintain limited access to care? In this case, through what we've seen, the organizing that happens with the Collaborative for Community Wellness, we were able to identify what are the social institutions that create the experience of limited access to mental health services in the city of Chicago. Through this, we were able to identify the medical system, right? We know that mental health care is very much medicalized in the society. The medicalization of mental health care very much creates a situation in which services are very much medicalized in a way that both limit the treatment options for individuals, but also makes them very costly and also very inefficient, right? So you think about hospitalizations, you think of managed care models, the pharmaceutical industry, right? You think about how this entire system, as many authors criticize, can be very much propense to institutionalizing individuals after the crises have emerged because of the lack of preventative care, right? So you think about how much money is invested into our medical system, and separately, right, thinking about the welfare system, how much money is invested here to prevent and support individuals before crises and mental health experiences become critical to the point that they need medical intervention, right? So thinking about how the welfare system is shaped in our society, right? Thinking about the social service organizations, the NGOs, right? The community-based organizations. Think about philanthropy. What role does philanthropy play in mental health access? Thinking about the publicly funded mental health services that the city once had, right? The city of Chicago once had 19 publicly funded mental health centers. This is the welfare system that has been reduced to 5 in the city of Chicago. We will be talking about the criminal justice system and what role the criminal justice system plays in mental health care access, right? Cook County Jail is the biggest mental health provider in the country, right? That is, again, not by accident, it's very much by design. The Chicago Police Department is very much the biggest intake force we have for mental health services outside of the medical system. And again, is that the best model for care? And finally, we have the education system, right? Many students are able to access mental health services through the education system, and many are not, right? And what school districts have access and mental health supports built into their funding structure, and which ones do not, right? Again, that is very much a system of design. So, when we look at Chicago and we think about, who has access to mental health care, who doesn't, through our research, we've been able to collect data that can very much quantify where and how people are able to access mental health services. And what you see, which should not be a surprise to anyone in the room, is that Chicago is very much a tale of two cities, right? You have what Chicago terms as the high economic hardship communities of Chicago, which are highlighted here in red, which are Chicago's wests, northwests, and south sides, and southwest sides of Chicago, right? The low-income work pool of the city, right? These are also the areas of the city that have highest rates of unemployment or highest rates of low-wage employment, right? And so, again, to me, seeing this as an issue that very much ties to what the workers' centers organizers were also bringing up, and the mental health concerns and health concerns that they were seeing in the workers, is very much the same map. We also see that the west side and the south side have the highest rates of behavioral health hospitalizations, right? This is where people, again, as I mentioned earlier, right, are receiving mental health care once crises have led to the point that people need to be hospitalized or offer no other choice other than to be hospitalized. And you see that predominantly in the Black neighborhoods of Chicago on the west side and the southwest side, south side. By comparison, one thing I always point to is that the southwest side and the northwest side, as we saw in the other map, which also high economic hardship community areas, have a relatively lower hospitalization rate, which again, I always have to make note of this, right? It's because those are also the parts of the city that have the highest uninsured rates, right? So this is the highest rates of uninsured in the city of Chicago. As a Black, you see the southwest side has the highest rates of uninsured individuals. And that is, again, because of people's immigration status. And again, people's limited access to mental health care has, by way of design of the system, has to go through the medical system, right? Which again, doesn't have to be that way, but the system is designed to do that. Research going back to 2015 shows that, the areas that have the highest rates of 911 behavioral health calls are also the ones that have the fewest services. Surprise, surprise, right? We understand that the closure of the public mental health system of that safety net has led to increased crises, and don't take my word for it, right? We have the data to prove it. What we see here on this map is 911 behavioral health calls by ward between January of 2019 and February of 2022. And once again, we see Chicago's west side and south side as the highest rates of 911 calls throughout the city. You also see this as the areas of the city in which 6 public mental health centers had been closed in the last 2 decades, right? So we think about the overlay here of the map where every one of those red X's was where there once was a public mental health center. And every one of those green dots is where the 5 currently operate. So as you can see, very much, this is what historic disinvestment and its impacts on present day realities looks like, right? What if those 6 mental health centers would still be in operation in those areas? Would there still be the level of 911 related 911 calls, behavioral health 911 calls happening, right? That's the question we have to ask. And I'm just realizing it's nearly 11 o'clock. Oh my God, I could talk for hours on this. And I'm
You're
realizing,
okay. No, this is great. Keep talking.
yeah, what's up? Just a time check. How much time do I have left?
Yeah, no, take your time. This is great.
Okay. All right. So, this is the data, and me as a researcher, right? This is where I think about our role as social work professionals, as public health professionals, right? What is it that the data can tell us, and how does that information serve the people in a way that we can work together to think about alternatives and building those alternatives together? Every one of these research projects that I've been a part of have always been shared back with our membership, and that membership has been very much part of the feedback structure we have to help us inform how, right, this data that we're gathering together, how we interpret the findings, how this data can then support our advocacy efforts, right? And this map that we're about to publish in the next few weeks will be part of what will be introduced to City Council to push for further investments in reestablishing public mental health services in the city of Chicago, reestablishing that infrastructure, but also thinking about what alternatives to 911 can look like, right? And how non-police crisis response is very much possible in our city, in spite of what the mayor has intended to do. So just also really quickly, this is the same map. Again, I can't leave out the comparison of communities that do not have those same rates on the southwest side and the northwest side of behavioral health related 911 calls, without talking about what is also the areas of the city that have at least 25% or more of its population as uninsured, right? So what you see as an overlay of this map are the areas that you see in light blue, white on the northwest side, on the southwest side, and on the far south side, are also the areas of the city that have the highest rates of uninsured, right? So the fact that 911 calls are not happening doesn't mean that there's not mental health crises happening in those areas. It just means people choose not to call 911 because they don't want to be stuck with a high medical bill in the event that an ambulance or an involuntary hospitalization happens, right? So again, really thinking about the system that's creating this lived experience for people, and the choices that they make is not a fault of the people and the choices that they make, but it is very much a fault of the system that designs that is designed in a way of creating people creating people's lived realities, right? Again, this is just a snapshot from 2017 when we started this research, of where and how investment in policing looks like as a percentage of our city budget. Policing makes up 40% of our budget. 40% of our discretional spending goes to police, right? In 2017, it was $1.4 billion. By comparison, at the time, $32 million was invested in public health, and a fraction of that, $32 million, was funding the public mental health centers, the 5 that are currently in operation, right? This is where Rahm Emanuel infamously wanted to save money when he chose to close 7 of Chicago's 12 public mental health centers. By comparison, again, for every dollar we're spending on police, we spend 2 cents on public health. And we saw the consequences of that, right? As we were hit with a global pandemic, I'm sure you all in the public health department are talking about this quite a bit, right? But if it wasn't for the federal investment that came to rescue cities like Chicago and many others, and I had this conversation with Commissioner Arwady actually before the pandemic, right? When it was on the radar, but it still hasn't reached Chicago. I remember we were meeting with Commissioner Arwady to discuss investment in public mental health services, and her biggest concern at the time was what were they going to do in the event of a pandemic reaching Chicago, as we ended up seeing the level of spending that had been, and the budget cuts that the department had gone through the previous administration is incredible, right? The amount of nurses that the public health department has lost throughout these decades is also very, very, very shocking, right? To see how our public infrastructure has been gutted, and very much privatized, right? You see the Department of Public Health very much give up its responsibility as a care provider, and it's seen itself as a philanthropist and health coordinator. That is not the case for public health departments in other parts of the world, right? Public health departments are very much seen as our public arm of service provision, and that is something that historically was the case in Chicago, but more and more as this neoliberal agenda takes place, privatization is very much what you're seeing more and more in what is the way we approach public health in the city. So we already talked about, right, where the intersection is between mental health and the criminal justice system. We know the amount of mostly Black men who have been killed when it comes to crisis response. We know that people with mental illness or mental health concerns are 16 times more likely to be killed in an interaction with police. We also know that Cook County Jail is the biggest mental health provider in the country, right? This is very much a system that's designed to provide access of care through our penal system in a way that is very much harming communities of color and harming individuals who are the most vulnerable in our society. We also know that that's not the case for everyone in Chicago, right? Again, going back to this map, right, we see the tale of 2 cities. Part of our research, we were able to actually count where every therapist operates in the city of Chicago. And what you see on this map is the data that shows that 78% of Chicago's residents, right, all of the pale yellow areas that you see in Chicago, all of Chicago's low-income communities, again, the high economic hardships and the medium economic hardships areas of the city, you see have an average ratio of therapists of 0.2 therapists per 1,000 community residents, compared to Chicago's most affluent neighborhoods, Chicago's Loop area, the near north and the north side, as well as the Beverly area and the southwest side. You're seeing has an average ratio of 4.3 therapists per 1,000 community residents. Right, these are the areas of the city that get the quality preventative care that prevents interactions with police, with hospitals, for people who are dealing with mental health concerns in those areas. Right, this is very much what inequality looks like. Right, this is where you see areas that have a household income that is twice that of the lower access areas. This is where you also see, and here we only have placed 12 public mental health centers. You see these are the areas in which the city closed 7 of the 12 under the Rahm administration. Right, these were the clinics and the areas that the current administration and Mayor Lightfoot promised to reopen in her campaign as her campaign strategy or platform. And it's not because there's been a lack of money that these public mental health centers have not been reopened. It's been because the city continues to operate with this neoliberal framework that looks to privatize care. Again, the cost to reopen those 7 public mental health clinics would be in the ballpark of $25 million, give or take, which again, candidate Lightfoot promised to invest at least $25 million to reopen those clinics. As mayor, she's chosen to invest nothing to reopen any of these clinics. And this is the same mayor who received $2 billion of federal relief, who received $600 million of the first wave of federal relief that was at her discretion to spend, and chose not to take from that $2.6 billion, $25 million to reopen these centers, right? Again, ideology is at play here. Ideology shapes the decisions, and the ideology of privatization instead of public investment is what's leading to the decision to continue to fund policing as opposed to reopening public mental health centers, right? We fund roughly 14,000 police officers as public servants, right? These are public employees that have full wages, benefits, pensions to quote unquote serve and protect, while we only have 20 therapists that are funded by the city to serve the communities. We have a portion of the nurses that once existed through the public system in Chicago available to community residents, right? Like that infrastructure, that public infrastructure has been gutted, and the ideology is persistent to say that it will not come back, right? And so that's why this campaign has taken so long for us, and it's not because there's not needs in the community. We know through this recent citywide survey that we did between 2020 and 2021 that we see throughout the city of Chicago there is an overwhelming need for mental health services. Anxiety and depressive symptoms are reported by the majority of respondents in this survey. We also know that 94% of Chicagoans are interested in seeking professional counseling services, right? Like, I don't think you get 94% of Chicagoans to agree on much else. But in this survey that we did, we found that almost everyone during this period in time were very much interested in seeking mental health supports. Did they have access is the real question. We also asked the question because again, there's this kind of there's this narrative that the city department, the mayor, the Department of Public Health will say is that, well, residents don't want to go to mental health services that are city run, right? They rather go to the neighborhood health clinic, the FQHC. And it's a very convenient narrative that they push, right? Because it fits this ideology that says that the city should not be providing services. The city is not responsible for services. The only service we should provide is police. And that's where a large portion of the federal relief went to, right? It went to support police overtime under the justification of community wellness checks, right? They gave the police department $260 million of the $400 available within the first wave of federal relief for wellness checks, right? Instead of funding clinicians to do wellness checks in communities that are publicly funded and operating through these centers, they chose to fund police to do this, right? And again, the data shows us that 90% of residents said yes, I'd be interested in going to a city-run mental health center that provided free services, right? The problem is only 27% of our respondents knew that the city actually runs 5 public mental health centers that provide free services. Many were under the impression that they were all closed. And again, if this model of privatization that the city has engaged in was working, we'd see that people would feel that there was enough mental health resources available in their neighborhood by way of any private provider that the city's funding, including nonprofits. But what we see, of course, is that 86% of respondents said no, they don't feel that there are enough mental health services available. And once again, the biggest barrier to care is not stigma, according to the data. It's the cost. It's the lack of health insurance. It's not knowing where to go. By comparison, only 11% of respondents reported stigma was keeping them from accessing mental health services. You know, the understanding that mental health care has to be provided by police is very much an ideological position that this mayor and others have taken. I don't know if we have time, but there's a quick 3-minute video for those of you who are not familiar with what the CAHOOTS model was. But for us, when we were looking at models of care that could be replicated here in Chicago, we were very much interested in learning more about CAHOOTS. CAHOOTS is a model, as you see in this picture, that sends behavioral health workers and paramedics to respond to crises, to tend to mental health needs of people in the community in a way that can be very much proactive, can be very much preventative, provide preventative care, and provide access to care in a moment of high need for an individual, instead of introducing police officers to the situation. So what time does how much time do I have? Do I have time to show this video?
Yeah, we can watch this video.
Okay. What time do I have to present? How much more time do I have?
I don't know, how much time did we have class till 12:30, but we have an activity afterwards, so we can spend like 10 more minutes if that's fine.
Okay, perfect. Okay, because
does anyone have questions too? I have questions.
Oh, sure.
Yeah. Yeah, we have time. It's fine. We can be flexible.
Okay, excellent. Okay, well, I want to show 2 videos because this gets to the core of our campaign. I've talked enough about the need for providing sustained public investment by way of establishing public mental health centers as kind of the safety net for our city. Again, it's necessary. The more that we think about public infrastructure, right? Think about your public library, right? Think about the school in your community. Think about the park in your area, right? All of these are resources that are publicly funded, publicly available. Why is mental health care not seen that way, right? Why is it that we think about the police and quote unquote training police to be better behavioral health workers as if that were possible, as the only option for publicly funded resources, right? So you think about Eugene, Oregon, and this is a quick example of what the CAHOOTS model looks like and how care is provided to people in crisis there. This program, I just want to start by saying, has been in operation for 3 decades now, right? So they have 30 years of experience responding to crises, and it's been seen nationwide as a model, as an example for care. And what we called for in 2020 when we introduced legislation calling for the establishment of non-police crisis response in the city of Chicago. So let me play this video. Let me know if the sound is working.
Today across CBS News, we've been taking.
Can you hear the sound?
Yeah, we can hear it.
Yep, perfect. All right.
An in-depth look at America's mental health crisis. We call our initiative Stop the Stigma.
Can you turn the captions on, please? Thanks. Uh-oh, now we can't hear the sound. Can you hear us, Arturo? The sound is off, I think.
Interventions and
How about now?
Yep, Perfect.
Okay, so I'll keep it unmuted.
We call our initiative Stop the
There you go.
Stigma. Nearly 4 million people in this country with severe mental illness go untreated. They are 16 times more likely to be killed during an encounter with police. Omar Villafranca shows us how one city is trying to change that.
There's a guy on River Road who I think would benefit from having Cahoots come visit him.
When a mental health related 911 call comes in, a specialized team in Eugene, Oregon rolls out.
Pretty much everybody we see is, for one reason or another, in a state of crisis.
Manning Walker is a medic, and Laura Lisovskis is a mental health crisis manager. The pair are members of Cahoots, crisis assistants helping out on the streets. They answer calls like suicide interventions and overdoses. They're unarmed, and most of the time, without police backup.
We always live as a team. Whoever is talking and making contact, the other person is observing.
They took our CBS crew on an exclusive ride-along. Their first call was for a woman they'd met before. They believe she's schizophrenic. She told us her name was Kayla.
Would you rather deal with someone with Cahoots or like a uniformed police officer?
Definitely Cahoots.
How come?
They don't, help you when you're in the time of need or when you're hungry or certain things like that.
Cahoots was founded in 1989. Last year, they responded to nearly 23,000 calls in Eugene and Springfield, Oregon. Denver is starting their own version of Cahoots. City leaders from Oakland, Olympia, Washington, and even New York City are all considering similar pilot programs. Tim Black is Cahoots operations coordinator.
We handle almost 20% of the entire external public safety call volume for our area. But there was such a dramatic need coming in through the 911 and non-emergency lines that there was a need for there to be this kind of behavioral health first response.
Let them know that you're out of your meds.
Cahoots team members are trained to de-escalate when responding to a mental health crisis.
Thank you guys so much.
A recent study found 25 to 50% of fatal officer-involved shootings involve someone with a severe mental illness. Eugene's police chief, Chris Skinner.
They don't need jail. What they need is they need to be able to be de-escalated from their crisis. They need a ride to a mental health facility or to a medical care facility or wrapped around with services. That's what the people need. They don't need to be going to jail every time.
A new way to protect and serve, and maybe save a life. Omar Villafranca, CBS News, Eugene, Oregon.
And
So for us, this was the model of care that we envisioned for Chicago, right? Like this is, in my mind, and my professional opinion as a social worker, what I see as the highest level of care for people throughout the city. Unfortunately, that was not the position of this mayor. And when she introduced her police reform package back in 2020, she called for the establishment of a police response model, right? What's commonly known as a co-responder model, in which police respond with a behavioral health worker or a paramedic to these mental health crises. She took it upon herself during the budget address to actually criticize the proposal and kind of ridicule it as something that wouldn't be applicable for the realities of Chicago, which was very much a dog whistling moment. And for us, we see that as very problematic. I want to show another video quickly. It's only be a couple minutes that highlights what happens in New York City when they established a pilot program that was also this co-responder model in which police are responding to mental health crises with paramedics and social workers. Many cities started by thinking about crisis response with police involvement, and this video demonstrates some of the dangers in that. So let me just show this really quick. Is this visible to people, this new screen?
Yeah, we can see it.
to the front lines of New York City's newest effort to reform policing. And that question, should police be the ones to respond to 911 calls about mental health emergencies? A new pilot program is about to send EMTs out with social workers instead of officers as they answer the call for change. Now, there's a range of reaction from optimism to safety concerns with this. Let's go to the I-Team's Melissa Russo with the exclusive.
No, y'all can't break my door. Y'all not gonna pay for it. You're not breaking my door.
Peggy Herrera called 911 because her son needed help.
He was having a crisis and he locked himself in the house.
Peggy was afraid of what might happen if police showed up.
I need the ambulance to show up first, not the police.
EMTs arrived with police, who could see her son through the window.
He's fine. He's there. You can see him. He's not bloody. He's not nothing.
But the situation went south.
No! Stop! Stop!
They grabbed him by the leg, pulled him down, beat him up. He never got the help he needed, and I spent the night in jail.
Encounters like these are why many are calling for police to be removed from responding.
So we don't have time to watch the whole video, but it goes on to talk about the viewpoints of non-police crisis response. What the city subsequently did was it established in New York City a citywide non-police crisis response team funded to the tune of $112 million. So they scaled up non-police crisis response citywide in New York City, right? And you know, this is definitely egg on the face of our mayor, who said that, you know, a model like Eugene couldn't happen in a big city like Chicago, right? When you think about New York City, it doesn't get much bigger than that. So, you know, what we put forward was establishing a pilot program that would operate out of 988. We wanted wanted to establish 2 public mental health centers to be triage centers that could be operating 24/7 to provide aftercare and support and provide a living room model of care to divert from having people hospitalized when dealing with crises. All of this and the money for it is very much possible. It's taken a big campaign and an organized effort citywide for us, involving consumers and people and advocates from all parts of the city to push for Chicago to finally include 1 non-police pilot team, actually 2, that are being now rolled out in the last few months. But once again, this city very much intends and has intended to have police crisis response be its central model. Through our FOIA submissions, we've of course confirmed that the design for this program is happening through the police department. It's led by the police department and the city has hired consultants from Texas to implement and justify the use of police in crisis response as they've done in Texas, not consultants from Eugene, as we called for, that have 30 years of experience working on models of crisis response without police. Denver has established non-police crisis response, Albuquerque, San Francisco, Portland, New York, as I just mentioned. Many cities are already moving past the police response model, but Chicago very much has centered its entire crisis response strategy around policing. Once again, because of our efforts, we were able to successfully push for the establishment of 1 non-police crisis response that rolled out beginning in July of this year. And the city has shared data on that. Even the crisis response teams that the city has shared data on that involve the police has shown through their own data that none of those crises have actually needed police involvement. So once again, it's just very much justifying what's not working, what's not needed, as other cities are moving forward in scaling up crisis response without police. And this is a list of those that I mentioned. With much more significant investment than what the minuscule pilot program that we have here in Chicago. Actually, there's a year worth of Denver pilot information from Denver that we've used to justify the fact that in all the calls that Denver has received throughout the first year of its pilot, none of those crisis calls required police backup. Right? Again, police backup is always available for crisis response teams if needed. But again, in the case of Denver, there was no need throughout the entire first year of its pilot. Subsequently, they've scaled up their crisis response to be citywide. You know, we choose to hire 14,000 police officers at a salary of $82,000 plus overtime, plus pensions. You know, that's the main service the city provides. Like, why? And I haven't heard a compelling reason other than they don't want to pay behavioral health workers $82,000 and offer them a pension. You know, that's the only reason I've heard from politicians as to why this hasn't happened here in our city. But we've included the voices of many social workers, clinicians, and we continue to fight. And as a result, we've increased investment in not only crisis response for non-police crisis response. All of the behavioral health workers from the crisis response teams are actually now, because of our efforts as well, part of the public sector. There was an intention we suspected to make them privately funded and operated positions, privately operated positions with public dollars, but instead now they're public operated CDPH positions. And we want to see that scaled up. We've also successfully fought for increased investment in the 5 public mental health centers for the first time ever. They are now offering evening hours of services. They used to close at 4:30 p.m. Now they're extending their hours of operation to 7:30, and we see the opportunity to increase that to 24 hours. And also, for the first time ever, they are providing child and adolescent services, something they haven't done in the past. So with that, I will share my information. That is a website of our coalition and our social media information for those of you who want to follow or find out more. Okay, so now I'll take any